Hi there, my name's Danielle Rankley, a program coordinator with the Upper Midwest Telehealth Resource Center. Thank you for attending this session of the Upper Midwest Telehealth Resource Center's Telehealth Bootcamp series. This series is being presented in collaboration with the University of Mississippi Medical Center's Center for Telehealth and the Ohio State Office of Rural Health. We're excited to be able to provide you with access to this incredible series, previously closed to the 2026 Telehealth Bootcamp applicants only. If you have more questions about telehealth or want to know more about the Upper Midwest Telehealth Resource Center, please come visit us on our website at umtrc.org. You can peruse our library of resources, check out our blog and podcast, and contact us to receive up to 10 hours of free telehealth technical assistance per year. Thank you again for joining us. Let's get started.
So, I think Shirsani may have mentioned this. My name is Meg Kwong. I'm with the Center for Connected Health Policy, and we are one of the 14 telehealth policy resource centers. We are the National Center on Policy. And she asked me if I could give like an overview of what's going on with telehealth policy and how that interacts with what the majority of you are interested in, which is how it interacts with management of chronic diseases. I'm going to pause there because I noticed in my video I'm like lagging, but are folks hearing me okay?
You sound great.
Yes, your voice is
Okay, I'm seeing thumbs up. I'm going to turn my video off for this just to make sure I have like a stable connection here. Y'all don't need to see me anyway. Stop my video. Sorry about that. I have been having issues the last couple of days with video, although the audio seems to be working okay. As I was saying, I'm one of 14 Telehealth Resource Center. I see some of my colleagues on here as well, representatives from the Southeast Telehealth Resource Center and the Mid-Atlantic Telehealth Resource Centers, and of course, the Centers of Excellence. We work with them as well, very closely on different projects here. So I was really happy to do this when asked. Just really quickly before we get started, I always have to start off each presentation with a disclaimer. Know that any information provided in today's talk is not to be regarded as legal advice. It is purely for informational purposes. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. And if I happen to mention a company or show a picture of a product, know that neither I nor CCHP has any type of relationship or affiliation with such a company. A little bit of background about us. We were actually established in 2009 as a California telehealth policy organization. We're a program underneath the Public Health Institute. We became the National Telehealth Policy Resource Center back in 2012. It's through funding from HRSA. Basically, we were tasked to really kind of help the regional telehealth resource centers like Matrix or Southeast Telehealth Resource Center with their policy questions. But we generally just provide that service, that policy help to basically anybody who asks us questions around telehealth policy. We also work with a variety of other funders and partners on the state and federal level, and we act as the administrator of the National Consortium of Telehealth Resource Centers, which I'll go into more detail in a second. And here in California, we're a convener for a group called the California Telehealth Policy Coalition, which is made up of statewide organizations specifically interested in California telehealth policy. The National Consortium of Telehealth Resource Center, just really quickly, because this is probably like kind of repeat for a lot of you. It's made up of the 14 telehealth resource centers that are funded through HRSA. A couple of years ago, we decided that it would be more efficient if we pooled just a little bit of our resources from our federal funding into a common pot, since there was so much common things that we were working on that could be shared across multiple regions or nationally, and we didn't each have to individually produce them. So when you're doing that with like funds, you got to have one person like administer them. So the other telehealth resource centers select a CCHP to just act as that administrator. Really, we're kind of just a point of contact. So to make it easier for everybody to like go to one point of contact as opposed to trying to contact multiple TRCs or, all 14 of them, they could go to one place and like have interaction or have contact or be referred to like the appropriate TRC. So if you are not familiar with them, I highly recommend that you reach out to your regional telehealth resource centers. They cover specific states. So there is one for your state. And territory as well. So, like the Southeast Telehealth Resource Center covers Puerto Rico and the Virgin Islands, where you have like the Pacific Basin, covers Guam and other territories as well in the Pacific Basin. Um, Again, they are among some of the most knowledgeable folks on telehealth. So they can answer practically any question that you may have, or if they don't know it, they have like the other telehealth resource centers to like reach out to, or, we all work together to try to find an answer for you. So again, if you are not familiar with a regional telehealth resource center, please reach out to them. They are an invaluable resource. And since we're federally funded, most of the stuff we do is for free. So what have you got to lose? All right. So when I was invited to speak today, I was asked if I could give like just an overview of what's going on with federal telehealth policy, which is mainly around Medicare, but also talk about other policy issues that would impact the use of technology to uh, basically you set up and operate a program that focuses in on chronic disease management. And some of the policy areas that I was asked to focus in on were on HIPAA and privacy, consent, licensure, and scope. I will warn you right now, this is going to be kind of high level here. Some of these issues can be very complicated and very detailed and very nuanced. Tirsani mentioned that I had asked, well, who is attending this webinar? Because especially when you're talking about the reimbursement policy, it kind of varies depending on what type of entity you are, like what you may have to do to get reimbursed for telehealth, or what you are allowed to do to use telehealth and expect to get reimbursed for it. It varies depending on what you are. It's different for like what an FQHC might have to do than what a private practitioner might have to do to like what a hospital might have to do. So we don't have enough time for me to like go into detail for all those. And sometimes, and I will admit, sometimes I'm like, I'm not sure. I have to go look up that hyper specific question, but I'll give you an overview of like, what's going on there. And if we can try to like get into more specifics in the Q&A or afterwards, if you want to send me the question, or one of like the regional TRCs, they can answer these questions as well too, after the webinar. That we're more than happy to try to like get that answer for you. But let's get into it, and we'll talk about the current federal telehealth policy, which probably a lot of you are aware of. So when you're talking about federal telehealth policy, that is policy that is specific to telehealth. It says telehealth in there in some place. It's really two places on the federal level. They're talking either about Medicare and like, what they would cover if you use telehealth to deliver services, or they're talking about prescribing controlled substances. So those are the two main areas in federal policy where they do have like the specific mention of telehealth in there. And there's like other policies, obviously, that impact the use of telehealth in some way that are federal policy, but they may not necessarily mention the word telehealth like within the policies themselves. But the two sort of like prominent or more well-known areas is Medicare reimbursement and prescribing controlled substance. And probably, as many of you know, where Medicare reimbursement is concerned and telehealth, we've been in this extended waiver period. And what that is during the COVID-19 pandemic, the Medicare telehealth policies, their permanent policies, were so limiting that Congress had to pass certain exceptions to it, temporary exceptions, to allow Medicare to reimburse for the use of telehealth in a wider capacity than what permanent telehealth policy allowed in Medicare. And those waivers have essentially been extended since the pandemic. And we've had like, extension after extension. We even had like a couple of brief periods of time where they were temporarily like expired. That was back in like, September of 2025 to like early November of 2025. We had that period there where like, oh, they expired, because a lot of those extensions have been in federal budget bills. And these like hiccups on like the extensions weren't about telehealth themselves. It was just that they happened to be caught up in like these larger issues that took a little bit longer to resolve. So you had these kind of brief pauses there in extension. But for the most part, there has been a continuous extension of these waivers that have been carried over from the pandemic, and they have been carried over again until the end of 2027. So, what are these extensions? If you look at permanent Medicare telehealth policies, it's very limiting. It has stuff like, well, you have to be in a certain geographic location to qualify for that service to be reimbursed by us, Medicare. Or you have to be a certain type of provider, and it's a specific list. Or it's like only these types of services, or it's only this modality that you use to deliver it. So what the extensions have done is basically waive those limitations for the most part, the major ones. So location requirements are waived. So there's like not this geographic and site. And what I mean by site, it's like a specific type of building that you need to be in. Under permanent policy, it's a very specific list, like a doctor's office, a hospital, a clinic. And this waiver, the site requirement, allow other locations, specifically like the home, to be a place where the patient can be when that telehealth interaction takes place, and Medicare will reimburse for it. They also expanded the list of eligible providers who could use telehealth and still get reimbursed by Medicare. Again, under permanent policy, it's hyper specific. People like speech language pathologists, OTs, and PTs are not on that permanent list. Neither are FQHCs and RHCs. So that's waived, and that's now, allowed at least until the end of 2027. There were also other policies in place, and this is kind of like where we start getting into waters where you say, like, this is getting a little complicated here, where they have requirements such as, well, an in-person required before you can use telehealth to provide mental health services, that would allow you to avoid having to meet certain other requirements, specifically like those location requirements. That's been waived as well until the end of 2027. Allowing audio only to be used for more than just mental and behavioral health services. And then, expanding the use of telehealth for recertification of eligibility for hospice care. So all of these like requirements, some of them you see like very hyper specific, were waived until the end of 2027, and that's because of HR 7148, which was a funding bill. There are a couple other things that I want you to be aware of that also 7148 did around telehealth that was not around the waivers. These are things that we will probably see over the next coming months, or maybe like early next year, that CMS will start putting out because they were required by Congress to do this. One of the things is like having certain modifiers created and put in place by the beginning of 2027. So that first bullet, that's something I fully expect to see in like the physician fee schedule and CMS like addressing that requirement by Congress. And then were other things such as, hospitals will be allowed to furnish and bill for Medicare for cardiopulmonary rehabilitation services to hospital patients, outpatients in their homes, if they're using live video. That second bullet addressed a gap in like the existing policy that CMS had. So this was basically, it was like physician-based practices that they were allowing for. So like the hospital outpatient one was like a gap in policy that Congress addressed, but they only addressed it through 2027. So it's a temporary policy as well too. So there are these like other things that are out there on like, besides around reimbursement. I mean, the modifier obviously is related to reimbursement as well as the second bullet, but there were other things not related to reimbursement that Congress is tasking CMS or HHS to like have done by certain periods of time. So there's going to be like other things out there that may just be like an additional resource for you, but there may also be policies that might dictate how you utilize telehealth to provide a service there. And then this was like some of the other things that were also in the bill. The first bullet, just want to spend like just a second on that. They extended the acute hospital care at home initiative until the end of, or September 30th, not quite the end, of 2030. So this was like a little bit of an outlier as far as like the time of like, when it would last. This was like a few more years that they added on there as well too. Now, I want to pause briefly to talk to you about that's like currently where federal Medicare telehealth policy stands. But I want to explain to you like how telehealth policy typically looks. And this means either on the federal or the state level. It follows kind of a pattern. And that pattern is that there are certain elements in like the telehealth policy that the policy usually addresses. And it's, where, who, how, and what. So the policy is usually crafted to address one of these points. It's like, where's the patient located? Who is the provider providing that service to the patient? How is the service being provided, and what exactly is that service? And if you look at any telehealth policy, it usually addresses one or more of these points. For example, let's say you have a Medicaid policy, a state Medicaid policy that says this state Medicaid program will reimburse for services when the patient is at home and it's being provided by a psychiatrist via live video, and it's mental and behavioral health services. So that policy there hits all of these 4 points here. And I want to like bring that up to you because when you look at like a telehealth policy, you will see that it is usually built around these 4 elements of how they're addressing it. So that's just something to keep in mind of like that's where you're going to see some of these requirements come up. Like maybe it's only specific services, maybe it's only a specific type provider, maybe they have requirements where the patient's located at the time of the telehealth interaction, and maybe they have like limitations of what type of modality you use. So this is kind of a breakdown of how you see that when you're talking about Medicare and what you're billing for. So when you're talking about like, provider type, it's like, okay, well, it's a practitioner. So right now in the waiver period, it's like, well, any eligible practitioner in Medicare. And then like they have a policy of like, well, what type of site is the patient in? And the site and geography in our waiver period is waived right now. And then they say, well, what modality can you use? Well, you can use live video or audio only at this point. And the service specific service list. So Medicare does have a specific eligible services list, and I've hyperlinked it here. It is like a specific CPT code. So it's not any service that Medicare will typically cover. It is a specific service that only these services you can use telehealth and they will pay for. Then they go into like a little bit more detail of like, well, how do you bill for it? What do you need to have on that claim in order to get reimbursed for? Like, is there anything else you need to do? And they say like, yes, there's certain modifiers that you need to put on there. And these are the modifiers. And that tells them like, okay, we know that if you use live video or audio only, or in very certain exceptions, they allow asynchronous to be used. And that asynchronous one, it is only for demonstration projects located in Hawaii or Alaska. So hyper specific again. And by the way, that asynchronous one, when you're talking about telehealth policy, that did not change. There was no waiver for that during the pandemic. So there has never been a waiver for that telehealth policy, that asynchronous policy, ever. So that was not something that they included among like the COVID waivers, and why you've not seen it into this extension period. And then they also ask for place of service, like, well, where did it take place? Like the home or like another location. So that's where that stands. Now, when I said earlier, I said, I kind of need to know what type of entity they are, or like how they're billing, like from like what viewpoint they are, because some of like those practices or what they do as far as billing differs. So comparing like what a practitioner does to like what an FQHC now needs to do and what policies apply to them when they're billing Medicare or they're using telehealth and Medicare. So very, very similar. Like they don't have to worry about site or geography. The site locations, those are way they can use live video and audio only. Service. This is where we start deviating a little bit. FQHCs and RHCs, when they're billing for mental and behavioral health, they do not bill that as a telehealth interaction. They can just bill that as a mental and behavioral health interaction. They just bill normally. And the reason for that was a couple of years ago, CMS made a definition change to what a mental health visit meant for FQHCs and RHCs, where they included live video and audio only. Audio only has some like requirements around there, but they made it a definition change. So when an FQHC, an RHC is providing mental behavioral health services via telehealth, that's considered like a regular old mental health visit for those entities. This is where you start seeing the sort of like deviation of like policies depending on what type of entity you are billing Medicare. It's also where you start getting into like, oh, this is getting kind of complicated and messy. Yes, it is. So sorry about that. That's just the way it is. I didn't write the policy. I'm only telling you, what it says here. However, if you were talking about a medical visit for an FQHC and RHC, that is considered telehealth. So they did not do that definition change for an FQHC and RHC in CMS. They did a little temporary extension. I'm not going to get into it because it doesn't really matter right now, because they got this waiver for FQHCs and RHCs to use telehealth to basically do any other type of medical services that are not mental behavioral health. But that is considered telehealth for FQHCs and RHCs. So instead, FQHCs and RHCs need to bill G2025 to like get reimbursed for that. And unlike the mental behavioral health visit where they bill it as just a normal old mental behavioral health visit, and they would get FQHCs and RHCs would get their PPS or air rate for medical visits, which are now considered telehealth, and you're billing G2025, you get a set rate that CMS has come up with. You do not get your PPS or air rate for billing G2025, which is for medical services. Again, where policy starts to deviate for depending on like where you are, and then even like, within like the specific type of entity you are, you have like this different policy, one for mental behavioral health and one for medical services. And then like the other things for it, if you're going to do like a modifier, you have to use FQ if you're using audio only. And then your place of service, the G2025, it kind of takes care of it. I'm going to pause there because that was a lot probably to throw at you, just to see if there's any questions. And I can't see all of you, so if anybody just wants to come off mute and just like say something, if they have a question, that's fine with me too. All right, I'm not seeing any, so I will continue on. I do have a hyperlink down there. Again, you guys will get a copy of the slides for the Medicare eligible telehealth service list. And that is very important. That does not apply to FQHCs and RHCs. It's going to apply to everybody else. Your service has to be on that list in order to get it reimbursed by Medicare if you are using telehealth. And then I also have on there a link to like Novitas, which is a MAC. So a MAC is a Medicare administrating contractor. Basically, they cover specific regions, and when you submit a claim into Medicare, they usually go to the MAC for them to process it. It's not like it goes to like a big CMS department. They like contract that out to these MACs. They are also a great source of like information about billing, and I have a link there to Novitas for that, for anybody who wants to check that out. But there are different ones for different states. So Novitas is not going to be the one for everybody. You just like need to check out like, or figure out which one is like your appropriate MAC. But they usually have like a lot of really good information on there as well too. If you have a specific question about billing and reimbursement, they're also the ones that you typically go to if you have like a dispute about like a claim. For example, if they like rejected your claim, and then they will be the ones that like tell you about that. They've gotten better over the years, but I will also say if you come across like something that just doesn't seem right with like if they rejected one of your claims, would you let your telehealth resource center know about that? They, like I said, the MACs have gotten better over the years, but there have been times where they have gotten the policy a little bit wrong. So the TRCs, over the years, we've been collecting some of those examples to see if like they've made a mistake. And sometimes it's just simply that they haven't cycled down to whoever's processing the claim like a new policy, and that's like easily correctable. But we like to keep an eye on the max to see if any weird things have happened. So if you do come across that in your sort of like telehealth journey there, let us know and we'll look into it as well. And see, if there's anything, if there was like a mistake made. Now, I talked about telehealth and Medicare policy. Here's again where the policy gets a little bit complicated. And here's where it applies to you because you're probably saying like you have not said anything about chronic disease or remote patient monitoring. And that is because when you talk about Medicare and using telehealth to deliver healthcare services, you are actually talking about two separate policies out there. You are talking about Medicare's telehealth policies, and you are talking about Medicare's communications technology-based services policy, CTBS. What is the difference? Well, first off, how are they similar? They both use technology to deliver a healthcare services, and the patient and the provider are not in the same location. Well, I just said that, and you're probably thinking, well, that sounds like telehealth. And I said, yes, it absolutely is, but it's also communications technology-based services. What's the difference? The difference is that telehealth policy is, for the most part, embedded in federal law. That's why it is so limiting, because all those requirements I said early on about, oh, you need to be in a certain geographic location, patient needs to be in a certain type of site, it's like limited to a list, limited set of providers. That is embedded in federal law. That is why Congress had to do those waivers. It wasn't just something CMS could decide on their own. They had to wait for Congress to act. It was in federal law, and in a specific says, this is telehealth. A couple of years back, even before the pandemic, CMS decided to create this new category of services which uses technology to deliver them, but they do not consider telehealth. They call it communications technology-based services. And in their explanation of why they made this distinction, beyond just saying that it was because, well, CMS, we're creating something, so it's not even in federal law. They said like it is different from telehealth because telehealth is a one-to-one replacement for something that takes place in person, a service that is like delivered in person. So for example, telehealth can replace like an office consultation. Like, yes, I go in and I see my primary care provider for like a visit or something. I can do that via telehealth. That is a one-to-one sort of like replacement for like in person, something you do via telehealth. CMS said communications technology-based services are different because they do not replace an in-person visit. These are services that you can do via technology that we typically don't do in person. And so we don't reimburse for those. So there's not that one-to-one replacement. And what comes underneath all those services, what doesn't take place in person that you can do now via technology? Remote patient monitoring. So that's where the remote patient monitoring stuff comes underneath Medicare policy. It does not come underneath their telehealth policy because telehealth policy, embedded in federal law, very specific, one-to-one replacement for something that usually takes place in person. Communications technology-based services, it's everything else. It's like stuff that they said, given the advancement of technology, we never considered, this could take place in person or it wouldn't take place in person. And that's where you find all your remote patient monitoring types of policies as well. It's also where you find other things such as your e-consults or your e-visits or your virtual check-ins. Virtual check-ins are those quick sort of like 5-minute conversations with like your doctor or something. CMS said we're going to pay for it, but they normally don't happen in person. They happen like you do a phone call or you send a quick email. Yes, we'll go ahead and pay for that, but they're really quick. So the thing is, the CTBS services, they're not telehealth. They don't have those telehealth restrictions, but they've got other restrictions. They've got other requirements that CMS has built around them that you would need to do, that you would need to meet in order to be reimbursed for them. For example, one of the big things is that CTBS services requires patient consent. all that telehealth stuff that I mentioned before, not once did I mention patient consent. It's because it's not in the telehealth policies. There was no requirement to like get patient consent for delivery of telehealth services. That is not in like that bucket of policies. However, it is in the bucket for CTBS services. So if you're going to do something like remote therapeutic monitoring, you got to get patient consent. Um, Now, there are other things that are other requirements on there for depending on what you're trying to do. They may require that it has to be patient initiated. That's your virtual check-in. It's because they're not going to pay for if like the doctor calls you and just wants to have a conversation. That's something else that they can bill for, but not underneath the virtual check-in kind of bucket of things. That's got to be patient initiated. Some of these require that it needs to be, it's only for an established patient. You can't just suddenly start doing this for a patient, for a patient that you had no relationship before. And then there are, specific documentations that they may require underneath specific codes when you bill for them. And they'll have that like in the explanation there. So keep in mind, we're going into like a different territory from like all that telehealth stuff I said before. This is communications technology based services, and it's got their own core requirements. And these are the things that fall underneath there in general, but each one may have like their own requirements and what they look for. So let's look at it. Remote monitoring and Medicare. So this is stuff from CMS Medicare Learning Network newsletter. It was updated in December 2025, and this is kind of what they say around remote monitoring. In general, it says like allows a patient to collect their own healthcare data, and then like it's transmitted to provider, and then the provider uses that to like kind of treat the patient's condition. There's two different ones. There's remote physiological monitoring and then remote therapeutic monitoring. Kirsten, at the beginning of this, when she was talking about like, how people have very different definitions of things here. I can't stress to you how important that is. We just saw that like through part of my presentations already, where I said telehealth is one thing, communications technology-based services another. You've got that here now. RPM, most people would think, oh, that's remote patient monitoring. Not underneath Medicare. They call that's for remote physiological monitoring. And then they've got another category called remote therapeutic monitoring. And they do two different things. And like they require like, different steps that you may need to take here. So these are like the difference between these two remote monitoring things that are going on. Remote patient monitoring is basically to like capture certain measures here, oxygen saturation, blood pressure, blood sugar, and then RTM is the non-physiological monitoring, and but it is also self-reported. And then these are like a couple other things, and like where RPM and RTM kind of differs. Like RPM requires established patient relationship, RTM does not. They both require like patient consent. You have to monitor for a chronic condition. You cannot bill the two together. And then certain device requirements need to be met, and then certain auxiliary personnel, like what they can like kind of do underneath this as well too. So depending on what you're doing and what you're trying to bill for, there are going to be these other requirements and other limitations there. Going back to telehealth, yes, they don't have the telehealth about like the geography and everything like that, but they do have hyper specific requirements on other things as well. I'm going to pause there to see if there's any questions. That we're getting into, it was a little bit weedier, a little more specific there on the policy. Just want to check in, see if there's like any immediate questions. Jeff.
Yeah, thanks, mate. Quick question on RTM. So our health system is looking to deploy that for the first time, and we're looking into kind of the licensing requirements in terms of the care team that's going to be providing that care through the RTM platform. And we haven't really found anything definitive in terms of if that provider has to be licensed where the patient is located, typical to your telehealth policy and requirements. Have you found anything, or is there any literature or requirements out there that kind of specifies those provider licensing requirements for RTM?
So hold that thought. We'll talk about licensing in a bit. So you're jumping ahead there. Um, but but basically, I don't think there is one specific to these policies because they just use like the Medicare general policy and licensing. So we'll talk about that in a second there. But um, before we get to that, I'm just going to cover a couple of other things really on the federal policy, and I'll explain why I'm not covering licensing specifically underneath like the federal stuff in a second when we get to it. But just really quickly go over here some of the other things. The HIPAA and the privacy issue is that even though you're using technology, you still got to abide by HIPAA. Now, this is like a little bit unusual in that HIPAA does not necessarily specifically have something on telehealth. They just have like your general HIPAA policies. So it does require a little bit of thinking, I think, by the practitioner to say like, well, how do we make sure that we're still abiding by these HIPAA policies that we're using telehealth. So keep that in mind. You still have to abide by HIPAA, but there's actually nothing specific, like no sort of nice handy checklist that HIPAA puts out that says like, okay, but if you're using telehealth, remember to do these things. There is like some guidance there that again, that's a hyperlink that I put on there from HHS on like HIPAA and the use of telehealth. So you might want to check that out. One thing I want to point out though, HIPAA always regard that as your floor and what you need to do. States may have more requirements or more stringent requirements regarding the protection around patient health information, and they're allowed to do that. So when you have like federal policy and state policy, you say like, well, who controls? Federal policy typically controls. However, if the state policy is not in conflict with the federal policy, their policy can also stand. So that's why I said HIPAA can be is considered that the floor. A state could have something that's like a little bit more hyper protective, a little bit more protective of the health information. And that's fine because HIPAA is like the minimum that you meet. A state can do say like, but you need to do something more. For example, like HIPAA says you do X, Y, and Z, and then state can say like, yes, you do X, Y, and Z, but we're also going to require an A, B, and C as well too. And that's perfectly fine as long as it doesn't conflict with anything on that federal policy there. So keep that in mind. Check out, the states that you're operating in if they have any specific requirements. One last federal thing that I want to go over, and this is what I mentioned earlier, sort of like the other big area as far as federal policy and telehealth, specifically to telehealth, is prescribing controlled substances. The prescribing and controlled substances, and when you're using telehealth, permanent federal law does allow you to use telehealth to prescribe a controlled substance in certain situations. And those situations are very, very narrow, very specific. So, they center around if the patient is with a DEA registered practitioner at the time the telehealth interaction takes place, or if they're in a DEA registered facility. And one of the exceptions also is when a public health emergency is declared. And that's why that waiver and that exception kicked in during the pandemic. That was never an action by Congress. That was already in federal law. It just got triggered by the pandemic. But when the public health emergency was declared over, that basically turned off the trigger. It was going to revert back to permanent policy to those very specific situations. The DEA has extended that waiver since the end of the public health emergency, and essentially have been doing that like every year. Currently, the extension for the prescribing controlled substance, and basically the exception is like, oh, you don't fit into one of those narrow exceptions, or you do not have a prior in-person exam of the patient by the telehealth provider before you use telehealth. So that's what's waived essentially, is that prior in-person exam or having to meet like one of those narrow exceptions. But that's only extended. That waiver is only extended till the end of this year to 2026. So I point that out because that does not align with the Medicare extensions. The Medicare extensions go to 2027. Currently, the prescribing exceptions only go to 2026, the end of 2026. So keep that in mind. Is is DEA possibly going to extend that another year? Possibly. They may do that just to match up with like what Medicare is doing. No guarantee on that. Typically in like the last couple of years, we start getting an indication of what DEA might be doing towards the end of summer, around September, and they start giving out hints on like, what they might be doing. I don't know if that's going to hold true. Maybe they'll like let us know sooner. But right now, that's one thing to keep in mind. That only goes to the end of 2026. Now, to get back to Jeff's question about licensure and scope, in general, the licensure question is left up to the states. So basically, what CMS has said is, well, we require you to like just follow the laws of like the states around what licensure, means. And I think for your remote patient monitoring question, Jeff, what you said about that, I don't recall them actually saying something specific to allow an exception for the remote patient monitoring thing. I think they're just going with their overall policy in CMS for Medicare in general, in that like you abide by like what the state says. And the states, for the most part, all say like, you gotta be licensed within our border. If the patient's within our border, you're providing a service to them, you're gonna have to be licensed. Now, there have been exceptions made over the last couple of years to that licensing requirement there, which is state dependent. And some of those exceptions have been, well, if you don't do like a lot of telehealth interactions with a patient in our state, or if the patient is like traveling through our state, or they're here temporarily, maybe they're in school, or they're a snowbird and they're vacationing there for a period of time. We've seen states make those exceptions. That is not consistent, and neither are the exceptions. So again, this is going to be one of those things where you're going to need to look at the specific state policy and what they do. There's also been the use of compacts to like get around that as well too, but all compacts are not created equally. So there are some compacts where they will allow you to have a one license and you can practice in multiple states, no problem, but they also have to be another compact state. That is like the nurse licensure compact. But then there are other compacts where say like, well, we're just going to this allows you to have a more expedited process to get a license in another compact state. And that is what the physician compact does as well too. There is over a dozen of different compacts out there now, and they have like differing policies. So again, depending on what practitioner you're talking about, that's going to differ for them as well too. But if you are, to get back to Jeff's question about what Medicare said, I don't recall them, when you're talking about communications technology-based services, of like having a licensure exception. So I would say that it is just their general policy in Medicare of, we kind of depends on like, we require the provider to like follow the laws of the state the patient's located in, which in general, just generally means that you're going to need to be licensed in that patient state, unless you fall into like some of the exceptions that they've created over the years. And that, again, is going to be specific to whatever state you're talking about. So here's an example of like, what that could look like. And I picked California and Illinois. California, some of the sort of like other policies like related to like what they may require is like there is a statutory requirement to obtain a prior consent from the patient before you even start telehealth services. So that's something to keep in mind if like, you're operating in the state of California telehealth. It's like you got to get that consent. That's required by law in the state law. And then California has a limited allowance on what they're going to allow a provider to treat a California patient if they don't have a California license. And the exception is extremely narrow. It is basically if a patient has no other hope of treatment because of their condition, and the only hope is like this other provider who's not licensed in California. That is like the only exception. Hyper specific, very narrow. California is one of these states that has like, the most strict policy around licensure. That's like the only exception they have currently on the books. However, you compare that to Illinois, no statutory requirement to obtain consent for prior to delivering telehealth services. Illinois also has like a temporary permit in certain situations as well, and they are a part of like some licensure compacts, the SIPAC and the medical licensure one. California not a member of any licensure compact, so you can. That's where I said like you can see the differences in the state and how they approach like the licensure and scope issue. Other state requirements, states can like have quirky requirements on what they are requiring if you're using telehealth. For example, Washington State back in 2021, they were requiring that, there's a telemedicine training that certain practitioners need to go through. That is required underneath their state laws there. So that's an example to keep in mind that depending on what state you're operating in when you're trying to provide your services, they may have like a quirky policy that you're not used to. But if you are going to operate within their borders because you're providing a service to a patient located within those borders via telehealth, you're going to have to abide by like those state requirements there as well too. I haven't even gotten to the reimbursement part of things. That was not what I was asked to do. These were the specific policy issues I was asked to talk about. But if you are trying to get reimbursed by like either like a Medicaid program within that state or by private payers, there's like also a whole other sort of host of potential policies that you'll need to abide by to ensure that you get that reimbursement. So that is about it. This is the CCHP website. We do track all of the state telehealth Medicaid policies, laws, and regulations for all the 50 states, and Puerto Rico and Virgin Islands. That's found on our website. You can like access it through there. We also have a newsletter that you can subscribe to. This is our contact information. I'm going to forward through that. And in the appendix here, I did provide some links that you might find useful to like their CCHP website, but also a couple of other links as well that provide some like additional information on some of the topics that I talked about. And that is about it. So I'm going to stop share and come back on. Let's see if I'm still lagging. And see if anyone has any questions.
So y'all, please don't be shy. I know someone has questions regarding this because these are questions that we get here at the Center for Telehealth all the time. And I'm sure that the TRC gets questions about this type of thing as well.
Sandy.
So thank you for the presentation. I know it's chock full of so much information. I just went to your CCHP website and I have to tell you, it's remarkable. I mean, that poster, that stick it kind of at the beginning that says what the state says about live video, store and forward, it makes a big difference because sometimes we're worried about, I don't know, the real source of truth, so to speak, if that makes sense to you.
Mm-hmm. Yeah, and
I just wanted to say thank you.
Oh, well, thank you. That's very kind of you. We do keep that updated on a rotating basis. I mean, you're looking at like 25% of the CCHP staff right now. So there's not a lot of us. So it's not like we can like update things like all that entire system like in a week or something like that. But things are updated on like a rolling basis. And that's like the key thing because legislation you can kind of time, because they have certain deadlines to meet. Medicaid, you just don't ever know when they're going to come up with like an update there, and they can come up with something that is like a real game changer. So thank you for the compliment. We do try to keep that updated as timely as possible, and that's really kind of the most important part, I think, of that. I know this was a fire hose, so I highly recommend if you can't think of your question now, but you think about it after like, I'm gone or something, jot it down. You can email it to CCHP. Tersani, I will like email you my PowerPoint so they have access to those links. But also, again, reach out to your telehealth resource center, your regional telehealth resource centers. They are fabulous. They know a lot of stuff as well, too. They can probably answer a lot of your questions, and you don't need to reach out to CCHP. Jeff.
Yeah, I do have another licensure question. So a lot of our providers work remotely or want to work remotely and provide services to our service area. Is there anything that outlines specifically we in our policies we tell the provider you need to be licensed in the state where the patient's located, but also in the state where you are located. On that second part, is there anything that outlines that requirement from the provider needing to be licensed where they are physically located?
It's gonna vary from state to state. There are a couple of states where they do specifically say like you need to be licensed in our state, and oh, by the way, you need to be licensed in the state that you're physically located in. And then there are also a lot of states that are silent on that issue. So I mean, I'm sorry to say this, but like you might think like it sounds like a broken record. It's going to depend on the state.
Yeah.
It's not clearly laid out on there. I'm maybe the Federation of State Medical Board has been like kind of good in the past. I have not checked them recently, so I don't know if they have this now. They have been good in the past about having like outlines for 50 state of like, what you might be required. But again, I haven't checked them in a couple years, so I don't know if they've updated that. But you can go to the CCHP website and like check. We will highlight if we found something where they said like you need to be licensed in like your home state as well too.
Yeah.
There are a couple states I know that do say that. I don't remember off the top of my head. I think most are silent on it though.
And is that driven by the state where the patient's located or the provider, or you probably have to check both, and it could be driven by both?
It's well, I'm not sure I understand your question driven by both in that, the state's going to have that requirement of if you're located in our state and you're practicing, we're going to require you to have a license. So
Yeah, it's generally based on where the patient is where licensure follows the patient. And then there may be some exceptions, especially if you are seeing patients that are located in the state where you're residing as well. But the general rule is it's where the patient is located. But there may be a few, like May mentioned, that say if you're in Mississippi and seeing patients in Alabama, I'm just making that up. It's not true for Mississippi, but I'm just saying that you have to be licensed in Mississippi and Alabama. But I personally have not worked in any or seen patients in any states where that was the case.
yeah, Jeff, and Tirsan is right. Jeff, I think in answer to your question, you'll usually see that policy pop up if a state is trying to address the fact of a provider coming within their borders.
Mhm.
So I don't know if that makes sense to you. It's not if that they just generally just put it out there, but they've written that policy in anticipation of like a provider coming within their borders to like treat a patient.
Yeah, our most likely scenario is like, so we have a 100% remote provider in Florida that wants to provide services back to Minnesota. And so I think from like a Medicaid reimbursement standpoint, Minnesota has said, we require the provider to be licensed in the state where they're physically located. But then Florida doesn't have any requirement that says, if you're providing services to another state, you don't physically have to, or you don't have to be licensed in the state of Florida. So it's very confusing. It can be kind of driven by both states in my experience. So that's where the confusion comes from.
Yeah, and sorry, I'm going to add to that confusion. In my mind, when I was talking, for the most part, I was thinking more of like regulatory and statutory policies because that's kind of what CCHP tracks. One sort of word of warning, you might also want to check like board policies, which is we have some of that if we found that on our website and our policy finder, but there may be a board policy that states something. So in your example, Jeff, like you have somebody who is, let's say, living in Florida and they are licensed by Florida, they want to provide services to somebody in Minnesota. But the Minnesota board has like a policy, like not in their laws and in their regulations, but they have it within like their board policies is saying like, oh, but you have to be like licensed depending on like where your location is, like where you're located. So
Your home state or
yeah, in
something.
your home state or something like that. That's also something I want to warn folks about. If like you also have to check some of like those board policies, which may be labeled as guidance or something like that as well. And
Great.
Mary's putting in the chat, like you also check with the boards on there. Yeah, because sometimes they don't have that publicly available, and that's one reason why CCHP may not be able to pick up on it. So, Sandy.
I have another one. So in the state of New Jersey, the Department of Health is encouraging people to become board certified in telemental health. Are you seeing this across the country? And then if you could comment on that at all.
Sorry, I had to go off for a second. So, the state of New Jersey are encouraging people to get board certified in telehealth.
Telemental health.
Telemental health, the behavioral health providers, like I know counselors in particular are having to go through that in some areas, and many times it's been the payer. I'm not overtaking your session, your
Oh,
question,
please.
but it is something. It is something that we've experienced too with not necessarily with our behavioral health program because we're seeing patients in Mississippi, but I wouldn't be surprised if it's more so the payers that are asking for that.
We're even
Have they
seeing
specified who is board certifying them in telemental health?
It's not by board certification. It is a certification. It's like telebehavioral health certification, telemental health, TMH. So
are they like running the certification like course? Like where are they telling them to like do the course?
Yeah, they can get the course multiple places, but it ends. It's like the six core principles of telemental health services. And yeah, it's just an additional certification, like for counselors mostly.
Yeah, it's very similar to that Washington example that I put up during my presentation. It's like a quirky thing of like we're gonna have you like do this extra sort of training there. My whole thing of like, I said, well, who's putting it on is like I understand the policy behind that for having that requirement. Who's doing that though? So yeah. I mean, like
you bring up a really good point, and so I know I'm getting bombarded with a lot of this stuff. Now, this came through the New Jersey Department of Health, and I'm not really trying to talk about them. It's the Center for Continuing Health Education.org. But I think some of us out here as consumers or consumers running practices are worried that you don't want to miss something because then you may no longer not be allowed to provide this care. Does that make sense? So it's a very dynamic environment of case. That's what it's
yeah. Yeah, and Mary put in the chat like who says a certification is qualified to teach. That has like been like one of my hesitations who's doing it. Now the Washington one is an interesting example. That was actually how the group that helped develop that is actually one of the telehealth resource centers. So that is actually somebody I kind of like trust there because it's like, oh, okay, we know them. But you are having like a lot of these groups out there that are just, putting out there like, oh, we have this course. And it's like, who are you? And how do we know this course is good there? So that's been something that I don't mean to speak for my fellow TRCs that are on here as well too. So feel free to like, violently shake your head or throw a tomato at me. It's like that. That's like a bit of a concern of like who's running these courses and how can a provider trust that, they're getting the information that they need from the course.
Hey, this is Tina Guston. I'm from Virginia, from CTR at ODU, and we actually have telehealth certification courses, and Dr. Weberly's online and knows our courses. And we offer CEU, and I stay very current on all of this. The interesting point, and your points are very well taken, is there is not really a process to have your course certified. We looked into it early on to have the course certified as a good course. And I think as an organization, that's probably something that you should take on.
Oh,
I mean, we'd be happy to have our course certified and people take it and say, content here is great, or you really need to strengthen this content. And we go back every year and update the policies and the legislation. But it would be nice to have a certifying body to certify your course.
I think again, my fellow TRCs throw a tomato at me. We would love to do something like that if the federal government would provide us with additional resources to develop that.
Girl, I get it.
Yeah. Yeah, I mean, it's been honestly among the TRCs, it's been something because we saw them, especially during the pandemic. They just started cropping up, and we're like, "Who are you?" These courses is like, I'm like, I don't say that
It's a
it's a
money
bad
grab
idea.
for some.
Yeah,
For some,
yeah,
it's a money grab. It's
yeah,
definitely.
like I don't say it's a bad idea. It's just sort of like, Tina, as you mentioned, it's sort of like, but has anybody kind of vetted you? And some of these courses may be fabulous. We've like looked at some of them. Some of them, it's like, is anybody gonna really sit through
I
all
mean,
this?
I mean, I think anybody who's doing this should want to be vetted and to get the feedback. I mean, I'm in academia. I mean, we get feedback all the time in our schools, what to change, what to keep, what to adapt. I mean, I,
Yeah,
I think whoever's doing the courses should lean into it.
yeah. No, I totally understand. If anybody wants to Lloyd, Mary, Kathy, $2 million, develop a course. It's probably gonna be sufficient.
So, I mean,
Yeah,
we
and I
have
think
courses, we have courses. I mean, I think there's quite a few, or I'm not quite a few, but there's a few TRCs that do have courses. Now we don't consider our certification. We consider, once people complete it, they get a certificate. Um, but there's no, I mean, we do have an organization that we partnered with. Um, that has accreditation. And so it does bring a little bit of, I think, credit to the course um, at the end, you get like, I think, 3 hours of credits. So, I mean, tying it through an accreditation source may be beneficial, but I think our fear, and kind of to reiterate what May, I think, was kind of saying, as states start requiring some of this certification, all that's going to happen is a lot of people is going to start popping up with coursework and, online courses. And how do if you're getting accurate information? So anyway, but I don't know. I mean, I don't know if there's a good answer. I'm like May. I don't know that I have time to sit to really put into into developing or even reviewing courses. I don't even have time to review our own courses. So,
Yeah. There was when I first started, and I've been doing this since 2010, telehealth policy. I remember he's retired now, speaking to a doctor from one of the major systems here in California. Kind like really like my one of my first people I ever met. Actually, he was in my interview with CCHP ever met for telehealth. And I just remember him saying, this is probably my first month working. He goes, I wish there was like a good housekeeping like entity for like telehealth and stuff. And that's like come up in my mind like over the years of like that would be great if and not to like brag about it. So I think the TRCs would be great to like be the ones who like run that. Um and maybe somebody will come up with that idea and say like, here's a pot of money, go ahead and develop that because we really need that out there. And I think that would be helpful, not only for practitioners, just to make sure, you know, they're kind of like dotting their I's and crossing their T's and everything. I think that would be really helpful for patients. For like, oh, okay, you've done this, you kind of know what you're doing and how to like use telehealth and everything. Because I can't tell you how many times that I've been on like, I always like it whenever I have like a health visit and they say, oh, have you heard of telehealth? And I always sit there and I go, you know what? Why don't you explain it to me? Because I'm going to be silently critiquing you and like your performance here throughout all that. So I do think that would be helpful for so many people. It's just been nothing that anybody's like developed. I think people have tried in the past, but it is like sort of a very, very, you know, huge. And I think we're probably gone over.